I am Roberto and today I have the great pleasure of interviewing my teacher and mentor, Dr. Robert Ojemann. This is a special privilege to me because I have clearly learned more about neurosurgery and about many other things from Bob than I have from anybody else, so it does give me a great deal of pleasure to have this opportunity, Bob. Today is the 2nd of May of 1990. And I think we could start by going back many years ago, I guess, into the time when you went to college. You went to college. Why don't you tell us a little bit about your early days in college and then medical school?
Well, thank you, Roberto, for those nice words. I was born in Iowa City and lived there throughout my early years through high school, and I actually started in college during my senior year in high school, which at that time was an unusual happening, but my father was in education and psychology and arranged that, and so by the time I had graduated from high school, I'd already completed nearly a year of college with summer school. So I went to the University of Iowa beginning in 1949, and spent 2 more years in the university, and then went to medical school beginning in 1951 and graduating in 1955. All of this was at the University of Iowa in Iowa City.
I understand you did relatively well in medical school. What was your class standing when you were finishing medical school?
Well, I graduated first in my class.
How many people were there in your class, Bob?
About 120, I believe.
Now, of course, those of you that know Dr. Ojemann will know that his brother George is also a very prominent professor of neurosurgery. And I wonder, what can you tell us about your family, your father and mother, that why neurosurgery, and what was the stimulus for 2 of you to go into neurosurgery? Your father was a psychologist, is that correct? Mm-hmm. Distinguished professor of psychology. Why neurosurgery for 2 of the boys?
Well, that's a good question and not always easy to answer looking back. My father and mother both grew up in very small towns. Actually, my father on a farm and my mother in a very small town in Illinois. And in their families, they were both the first to go to college. The interest my father had in psychology had involved some work with psychiatrists, and there was never any question about the fact that we were going to go to college and go into profession. And I can't say that there was any one event. I did have a distant uncle who had been a family country doctor, but never really knew him. I guess the thing that brought it all together was my father's interest in things that related to the nervous system, my interest in biology beginning in high school with an excellent teacher, and in science in general. At one point I had thought about majoring in either biology or physics. And then I had always enjoyed doing things with my hands, a lot of carpentry work and woodwork. As I got into college and the interest in biology, I had more exposure to some anatomical neurobiology courses, and I think all of those factors led to going to medical school. I had pretty much knew almost right away I wanted to be in a surgical specialty. And one of our good family friends was Dr. A.D. Saws, who was one of the premier neurologists of his time in the country. And in those days, a medical school consisted of 9 months going to school and then a summer time of either off or you could take electives, and I chose to take an elective on neurology as a medical student, not really having had any clinical neurology, but starting out really doing a research project on dilantin toxicity under Dr. Saws and Dr. Utterback, who subsequently went to the University of Tennessee, and the senior resident was Bob Joint, who became a professor at Rochester, now I believe a dean. And those three people had great influence on solidifying the interest in the nervous system. And my first research project was giving dilantin to cats and looking at their ataxia and the pathology in the cerebellum at that time. And that, along with my interest in surgery, really evolved to neurosurgery as being interest. At that time, Russell Myers was the neurosurgeon at the University of Iowa, and he'd embarked on a very elaborate investigation of the use of ultrasound to make lesions in the nervous system. And while I was not directly involved with neurosurgery per se, since the medical students really didn't have a rotation there, I had a lot of experience in the operating room and had observed these fascinating investigations.
And then you went to internship.
Yes, I graduated in June of 1955, and at that time, to go into neurosurgery required a internship plus a year of general surgery. Those were requirements before you could take the four-year neurosurgical residency. And I decided I wanted a more general type of internship for general education. So I took a rotating internship and decided on the University of Cincinnati, Cincinnati General Hospital, which really was an exceptional experience in all of the major disciplines. It really gave a broad fund of knowledge and just really built on what had transpired in medical school. I enjoyed that year very much, very busy.
And then you went to Houston for a year of general surgery?
I decided that I'd like, for that year, which I knew was only going to be a year, I would want to go someplace where there was someone that was working on new things. And I learned that Dr. DeBakey, who was at that point really getting into the vascular surgery investigations, and had positions in his program that were only 1 year in length and were geared for those who planned to go to another specialty. And I was fortunate to go then in the summer of 1956 to Houston for a 1-year general surgical residency, which again was just a great experience. I spent 3 months in the general surgical service at the VA hospital, and at that point in time, Dr. DeBakey was still, or was regularly making rounds there, and I'll never forget some of the weekends when he would come in on a Sunday morning at 6 a.m. and just you and he would make rounds on the surgical patients, and you better know what was going on. And then during that time, I had 3 months in the private hospital where I got to see both he and Dr. Cooley. Denton Cooley were working there at that time, and there were some of the very early investigations and clinical work that Dr. Cooley was doing was going on. And I had 3 months on orthopedics and 3 months in the emergency or in the general surgical service of the city county hospital. And I think with those 2 rotations, I probably put a rod in every long bone of the body and explored the chest and abdomen. It was an excellent background. And in those days, why, of course, there wasn't any matching plan, and Dr. Sweet happened to be in Houston, and I had already applied to neurosurgical programs, and he interviewed me there, actually, rather than my making the now trip that everyone makes, and he offered me the job. It's a little quite different than now, and I'm sure Dr. DeBakey's input had a lot to do with that. Well, I'd had as I said, a very nice experience there. In fact, about halfway through that program, he tried to see if I wouldn't want to be a cardiovascular surgeon rather than a neurosurgeon, but I was pretty set on those.
What made neurosurgery residency at the Mass General at that time attractive to you?
Well, I guess I could ask you the same question for later on, but
you made it attractive for me. But
yeah, right. At that time, it was considered one of the premier programs, and I had picked out what I thought were several of the programs that one, mostly by word of mouth, could determine were the programs that had not only a good clinical experience, but also provided the opportunity for investigation and research. And at that point in time now, we're talking about the 1956, 57, looking toward a career that would involve research. It wasn't something that was all that available as it is now. There were only a very limited number of programs, and certainly Dr. Sweet was one of the real pioneers in, as was the group in St. Louis and subsequently Dr. King, but in providing the opportunity for the resident not only to have a good clinical experience, but also the opportunity to learn what laboratory investigation was all about and how that could be applied in the clinical setting. And so the program offered the opportunity to have that experience if one wanted to take advantage of it. So I came to Boston in July of 1957.
Okay. Now, anybody that knows Bob Ojemann knows how important Gene Ojemann has been in his life, and it's been not only his constant companion, but best friend. And when did you and Gene were married?
Well, we were married at the end of medical school. I graduated one week, got married the next week, and a couple weeks later started my internship. And
so she followed you around through this?
Yeah, she was with me all of that. Well, actually, it was a fortuitous happening that we met. I alluded earlier to this project on the Dilantin, and there was one other medical student I worked with on that, and this was as a freshman, and we, of course, were good friends. And beginning of my senior year, he said his fiancée had a new roommate, and would I like to go on a blind date? And so that was that's how it all started, and that was about in the fall before of my senior year.
Great. Well, going back to your residency, you found time during the residency to do some research, and in fact, since you're too humble to say it, I will say that research won the prize for the best research done by any resident during that year by the American Academy of Neurologic Surgeons. Can you tell us a little bit about how you became interested in research and what is it that you did that led to that prize?
Well, Dr. Sweet, as I said earlier, provided the option and the opportunity to undertake that, and he was very interested at that time in radioactive isotopes for both scanning, that is brain scanning. We didn't have, of course, the CT scan and the MRI scan at that time, and the radioactive isotope offered a very helpful adjunct to the localization of particularly tumors, but also helped with some vascular problems. And I had also been, with my physics interest, I found this problem of interest, and I looked at the possibility of isotopic therapy for certain types of brain tumors. So I did an extensive laboratory investigation of some particular isotopic compounds that might be activated with short half-life in the cyclotron that would not be toxic and would be taken up in the tumor areas. So it was an investigation that looked at this in great detail and came up with a couple of potential compounds that one of which was even carried to the status of a clinical trial, where as with many investigations, it was found that the uptake in the clinical setting, the differential uptake was not enough to give the radiation dose that we had hoped for. But as we all know, not every investigation is totally successful, but it did lead to a number of publications and really provided me with an opportunity to do something I had not had a chance to do before, and to learn what was involved in some of the academic aspects of medicine.
Okay. Well, I am told the rumor, the story, the legend at the MGH, the Mass General, is that the day you finish your residency, you were extraordinarily busy already when you immediately joined the staff, and I understand that one of the reasons for that was the very excellent relationship that you had already developed as a resident with some of the neurologists on the staff. At that time, I guess it's fair to say that the neurologists had the bulk of the patients that were referred to neurosurgery. They came for workup and they were referred to neurosurgery, and there were some prominent figures in neurology at that time that have remained very much a part of your career through the years. Can you tell us a little bit about your early relationship with some of the neurologists at the MGH and how that evolved?
Well, that was really a era of that when you look back and you had Raymond Adams, Morris Victor, Miller Fisher, Phil Dodge, all of whom were in themselves really legends in neurology, and there they were all in the same department. We, at that time, were also fortunate in that the neurosurgeon rotated on the neurology service as part of the residency to obtain that training, and there was a reciprocal rotation from neurology to neurosurgery. And some of the individuals, chief residents that I knew at that time, I still correspond occasionally with, and but the opportunity to work with, in particular, C. Miller Fisher, who I was fortunate enough to have as a visit when I was on neurology, and who I developed an interest in cerebral vascular disease, and he had just a few years before began to, or did focus on the problems of not only the stenosis of the carotid artery, but many of the syndromes that related to that from the intracranial circulation, and he also had a keen interest in a number of aspects of hemorrhagic vascular disease as well. So and Dr. Sweet had encouraged me to develop skills in the vascular area. I had certainly initially had that interest when I was with Dr. DeBakey, and Dr. Sweet was one of the early people to begin carotid endarterectomy, and he steered me in that direction. And then with Dr. Fisher's interest, and we had a very good working relationship in this area, why I developed a particular interest initially in vascular disease, but also in all aspects of cerebral vascular disease. But at that time, why we were doing everything in neurosurgery. I mean, we were doing spine surgery and tumor surgery and pain surgery, and you were the general neurosurgeon. We didn't have
a lot of pediatric surgery.
And pediatric surgery, right, with Phil Dodge. And there was not the subspecialization at that time. Now, that was in 1961. As time went along, again, because just there isn't time to do everything, why my interest centered on tumors and on vascular disease, although I still continue to do a fair amount of spine surgery as well. There were a number of very talented younger neurologists coming along at that time as well, and it was just an excellent working relationship that I was fortunate enough to have with them, and certainly without CT and MRI scans, why, as you said earlier, more patients did come directly through neurology at that point in time. We were also increasingly busy with the tumors as well.
Would you characterize that very close relationship between neurology and neurosurgery at the MGH as being peculiar of an institution at that time? Or it seems to me that as I have left, I see less and less of that, and you feel that that was an important
well, I think
factor for you throughout.
Yeah, I think that's been just a great plus to the institution, that that relationship could work out, and it has remained a very close relationship over the 30-some years that I've been there. Through Dr. Adams' tenure and then Dr. Martin's tenure, why and Dr. Sweet and Dr. Zervis' tenure, why it's remained a very important factor, very, very close relationship.
Now that relationship and that collaboration led to some landmark papers during those early years when you were at the Mass General in a variety of subjects. Maybe you can tell us a little bit about some of those. I can recall the normal pressure hydrocephalus and carotid,
right,
a number of others, carotid dissection, cerebellar infarction, etc. Can you tell us a little bit about some of those?
Well, in the vascular area, again, working with particularly Dr. Fisher, why we had made some of the original observations relative to cerebellar hemorrhage, and then with some of the other neurologists, the cerebellar infarction. We described the initial radiographic appearance of carotid dissection and gave that description, and the so-called string sign came from that article.
Was it also perhaps the first operation performed for a carotid dissection?
It may well have
that you
been. I don't
reported on?
remember that for sure right now,
It's
but
my feeling that that probably was the first report of a successful surgical correction
for
of
that.
carotid dissection.
Right. And then Dr. Fisher, over the years, working with him, has made a number of observations relative to the pathology of the carotid plaques, and also some of the pathology related to problems in the intracranial hemorrhage area. Then we had one of the very early articles on really the carotid endarterectomy technique and the results of that. And then later on, as an extension from some of that, had one of the largest series working with you on some of the acute carotid problems. And this all in the vascular area led to publication of a book. But going back to the 1960s, you alluded to the normal pressure hydrocephalus, which really I was involved in the surgery for that, but the ideas for that, of course, came from Dr. Hakim and Dr. Adams and Dr. Sweet. That really were the ideas for that generated, and I did make some other observations relative to that in some subsequent papers. And then the tumors, particularly the angle tumors, particularly acoustic neuromas, I began to become interested in working with both the otoneurologist and the otolaryngologist from the eye and ear, and we reported some of the initial staged operations for acoustic neuroma, and then later on have made observations, I guess probably the largest series relative to trying to preserve hearing, and some clinical investigations relative to using intraoperative monitoring to do that. And these, of course, have been done with Bob Levine, the neurologist, neurophysiologist, and Bill Montgomery, and then Joe Nadal, have all been involved in that project. There have also been a number of observations in the area of the meningiomas and in some of the surgical techniques that are utilized in the treatment of that tumor.
Well, you mentioned very briefly the book that you wrote on cerebrovascular disease, and I'm familiar with it since you were kind enough to allow me to participate on the second edition. But as I understand it, this probably was, I can't recall seeing another comprehensive textbook on cerebrovascular surgery that was essentially, I don't know what you call it, monograph, but with two authors rather than a multi-authored book. And of course, both you and Bob in the initial edition had wrote every one of the pages on the book, and knowing you, I'm sure you you read and reread many times each word on the book. How much work was it to produce the initial edition?
That's a good question. A lot of work. That book started from scratch. I decided that there was, as you said, there wasn't really a book that focused on the surgical management of cerebral vascular disease. We had books on stroke, and we had sections in the textbooks on surgery, but there wasn't a book that focused, and there wasn't a book that showed how one group, did something. And I thought it would be worthwhile to have a technique, or one set of techniques that published, that at least people could look at and say, well, that's how they do it there, and they could alter it or change it, but at least it was there for people to look at and to see how we did something, and it was a technical book. The purpose was to give some clinical description, but then to give with detailed drawings with the help of Edith Tegern and working with Bob Kroll, detailed drawings of operative technique, but also to include results and complications and how to handle those, but to do it in a concise, organized fashion. And I don't know how many man hours it took, but it took a lot. And I, at one point, was trying to spend every Friday doing that, but only about half of them, I guess, where that was possible. And it took quite a while. But then you came to the General, and we did the second edition with Bob and yourself, and enlarged it and amplified on many of the sections, and it, I think, remains the only comprehensive book. There have been books on aneurysms and books just on carotid disease subsequently, but this, I think, remains the only comprehensive book on that. And it's a lot of work, but it was enjoyable when it's all done. Sure. Looking back on it.
Now, you have also co-authored with Charles Poletti a book on stereotactic pictures, essentially a technique book covering a wider range of neurosurgery, which is based to a large degree in your operative experience. And, that was published when?
Well, I think about 5 years ago now, something like that. It was a book where 3D operative slides were taken primarily of tumors, I think, but also a number of vascular cases, and presented with a description, a picture with captions describing what was seen, and then a viewer that came with this with a little circular that one could look through the viewer and see the three-dimensional color aspects, as well as looking at black and white picture with the anatomy and the pathology outlined on it. And it's been, I think, very useful as a teaching tool for the residents and the neurosurgeon who perhaps hasn't done something for a while and wants to refresh their memory on the anatomy of the. But Charles did a lot of work on that.
Well, we'll come back at the end in more general terms to talk a little bit about your clinical experience and where you see clinical neurosurgery going and so forth. But I do want to go back now to sort of a second parallel career that you have had which of course is being very much part of being a neurosurgeon, but I'm sure is an area that has given you a lot of gratification, and that's the area of national neurosurgical organizational politics, so to speak. And it is my understanding that you're perhaps the only neurosurgeon who has been president of the Congress of Neurologic Surgeons and president of the AANS, the Cushing Society, as well as chairman of the board of neurosurgery. And currently you're president of the academy, and I understand now president-elect of the Society of Neurologic Surgeons. And tell us a little bit about how that all started. How did you get started in that direction? How do you find the time to do it? Has it been rewarding? Has it been important?
A lot of questions. To start, I'll start a little bit backwards. First, it's been very rewarding. It has taken a lot of time, and sometimes you wonder whether the time is really worth it, but in the end, I think it is. And I think neurosurgeons should be involved, because a lot of the things that we do in those capacities do relate to the future of neurosurgery. Back in the 1960s, as I was getting into all the aspects of neurosurgery, I was going to some of the meetings. In fact, the first meeting I ever went to was while I was a resident. Dr. Sweet took me by train to an academy meeting in Toronto, American Academy, and that was quite an unforgettable experience. The first meeting as I say, that I'd ever gone to. And first time I ever went on an airplane was to a meeting in Washington, D.C., I believe of this organization. I had a very good friend in Boston, John Shillito, the senior neurosurgeons at the Children's Brigham, and he was quite involved in the activities of the Congress of Neurologic Surgeons. And early on, he'd asked me whether I wanted to get involved in some of their activities, and I said fine. And I've forgotten exactly what I was doing initially, but it was a committee with a lot of members and not too much to do, but I did enjoy the meetings. And then I, of course, had some publications by that time and had written some things. And one of the things I did was be on the editorial group that was doing clinical neurosurgery, and reasons I don't totally know why I eventually became editor of the yearly clinical neurosurgery volume, which is a volume the Congress publishes each year from their meeting. And one day at a Congress meeting, Bill Mossberg from Maryland, who was also a visual, came up to me out of the blue and said, "How would you like to be on the executive committee of the Congress?" I said, sort of asking what that entailed, and I didn't sound like too much. It turned out to be a lot more than I thought, and so I became a member of the executive committee of the Congress, and found that I enjoyed both the opportunity to do something that related to, at that time, primarily the ongoing neurosurgical education, and particularly resident education. Because one of the things that actually over the years I've really been most interested in and has been most rewarding is resident education, and the Congress stresses that. And I enjoyed that, and I also, as a parallel to that, enjoyed very much meeting many other very capable neurosurgeons, and then socially they and their wives, and made some friends that have remained friends throughout my neurosurgical career. They decided at some point that I might be a good secretary for the Congress. At that point, there was no executive director, no central office, no one in Chicago to run a meeting. The secretary was the organization. Everything went through the secretary's office, not only the ongoing day-to-day, but when it came time to a meeting, the secretary printed the programs, or arranged to have them printed, dealt with a hotel, and dealt with all the other committees that were involved in this very voluntary effort, the program committee and the host committee, and all the committees that the Congress had. And fortunately, of course, the Congress did supply the funds to hire a secretary for that, but it still took a lot of one's personal time to be sure that that was running along all right, and one really gets into education and in dealing with the day-to-day activities that are involved in a large organization. And then that led up to my then subsequently becoming president of the Congress in the mid-70s. And there were a number of things about that, but one that stands out is that the first meeting, or the first joint officers meeting between the Congress and AANS occurred when I was the president of the Congress. I did not initiate it. It was initiated by Lester Mount, who was then the president of the AANS. Lester Mount and Don, I believe it was Don Doan, who was the secretary, and myself, president, and Dave Kelly, who was the secretary of the Congress at that time, met in New York for the first joint officers meeting ever between the AANS and the Congress. And I think that was very important because the two organizations up to that time had been to a certain extent competitive. That's not to say that hasn't come up again from time to time, but there had been the Mayfield Proclamation earlier, but it really, the two organizations really working together for the common good of neurosurgery and the common goals, and for the AANS being the spokes organization, but still having input in the Congress, really came about to a great extent from that beginning, and those joint officer meetings now, of course, evolved into a meeting of all the officers twice a year on a regular basis. So I think that was important. The other thing that occurred during that time was that while it had been talked about for a period of time, why we finalized the development and the publication of the Red Neurosurgery Journal, and that occurred during the time that I was president. And in fact, I talked Bob Wilkins into being the first editor of the Red Journal, and we all know what has happened with that journal since then.
And then the ANS.
Well, at that same time, about the time I finished that, I became a member of the American Board of Neurosurgery. That was from 77 to 83. And in 1981, the AANS met in Boston for their anniversary, 50th anniversary meeting, and Bob King was the president, and he taught me into being the local arrangements chairman. And that was when I really began to know the AANS organization per se, and after that I did become a member of the board of directors of the AANS, and I was then finishing my time on the American Board of Neurosurgery. In the last year, which was 82, 83, I was chairman of that board, and that was a busy time in the certification problems and the written examination problems that were ongoing at that time. But I had a number of jobs with the AANS, including the future meetings sites chairman, and a number of other things, and I again enjoyed that very much. And it does take a moderate amount of time. I'd been a member of the finance committee, and then subsequently the long-range planning committee. And one thing led to another, and they asked me to be the president.
And then what happened? What do you remember during that year that was particularly rewarding to you? I know a lot of things happened, and it was a very busy year.
It was a very busy year, and that's become a very busy job with but the highlight of the year was, of course, the Cushing Stamp. And what made it such was that as President-elect, Eben Alexander had written me and said back in the 60s they tried to get a stamp printed to honor Harvey Cushing for his 100th anniversary of his 100th birth, 100 years since his birth, which would have been 1969, and they weren't able to do that. And he said, shouldn't we try again? And I had been a stamp collector in my youth and had not been active in that in recent years, but still had an interest in it. And so I brought this up to the board of directors, and the concept was approved. The question was how to implement that. Charlie Plant, our Washington liaison representative, began the bureaucratic process to get a stamp, and one is competing against, I guess, more than 1,000 other entries, so to speak, for a few stamps that are produced each year. But that process was started, and at the same time, it was clear that we needed some help in the political process as well. And we enlisted the aid of Dr. Dick Davis, a prominent neurosurgeon in Philadelphia, who's the brother of Nancy Reagan. And it turned out that, which I hadn't realized at the time, but was made aware of, that Mrs. Reagan's stepfather, Loyal Davis, trained with Harvey Cushing, and the postal service felt that in their committee that the application was appropriate because of his contributions and historical interest. And then Mrs. Reagan decided that she would like to host a gathering to announce this stamp. So on a beautiful April afternoon in 1987, why in the Rose Garden, a small gathering, the president and the then Postmaster General unveiled the artwork for the stamp. And then after that, Jean, my wife, and I, and Dr. and Mrs. Davis, and the president and Mrs. Reagan sat down like we are in the Oval Office and talked for 15 or 20 minutes in a conversation that was very easy. He was very easy to talk to, and which is, of course, one of those unforgettable things that one never forgets. And then my wife and Mrs. Reagan, President, and I walked over to the state dining room where a reception was hosted, and they greeted all the 100 and some people that were there, shook their hands, their picture taken, and spent a little time there. And it was a day enjoyed by everyone. And when we talked to the president, we talked somewhat about Cushing and about Cushing actually had been in the White House on more than one occasion. And then we discussed the artwork that was in the Oval Office, and it was also something about the president picked off his desk a model of a new airplane, and he said he had become president too early. This was a plane that the Joint Chiefs of Staff had given him this model that morning that was going to be able to land vertically outside his door in the Oval Office and fly to Camp David in a few minutes. And so that was a big event. And then the stamp was actually printed the next year after the postal rate changed, and we had a beautiful ceremony in Cleveland where Cushing had been born, that the first day of issue ceremony. And all of this, the other factor in all this was dealing with Cushing's only surviving daughter, Mrs. John Hay Whitney. And Mr. Plant and I spent 2 days separate days visiting in New York and in her penthouse apartment and out in her Long Island estate, which are just unforgettable trips and visits in themselves. And she's a very lovely lady, and she approved the various designs and drawings and all of the arrangements, and actually was a co-host to our reception in Washington after this announcement by the president. So I guess one would have to really say that was the highlight. But
Yeah.
but the working with Mr. Halber and working with the board of directors and dealing with just one problem after another, reimbursement, medical legal problems, the government wanting to have information about the bypass study and about carotids and about certain kinds of tumors, and hospitals wanting information about neurosurgery and other specialties, and dealing with the problems of interfacing with other specialties. It's a remarkable year, and I wouldn't want to do it continuously.
Well, you're taking on the presidency of the academy, and then in rapid succession the society.
But that's
those are easier jobs.
That's nothing like being the president.
No less of an honor.
AANS.
We cover a little bit some of your proudest moments, so to speak, in neurosurgical organizational politics in your clinical practice. One of the areas that we haven't covered, and I'm sure with your humility it'll be hard for you to say much about it, but all of us who train at the Mass General remember you as clearly the premier teacher and influence and role model that we wanted to follow as we became neurosurgeons. And what can you tell us about your commitment to teaching and your relationship to the residents, and how much did this mean to you and does mean today, as you look back and see so many people that you have had a major influence in their training go on to be successful neurosurgeons?
Well, thank you. I guess my first concern and my first priority has been to try and give the best patient care possible. But as part of that, I guess as rewarding has been the teaching of the resident. And one of the most enjoyable things has been to watch the resident grow and develop in their surgical judgment and their surgical skills and their ability to assess a problem and to deal with unexpected emergencies and complications, and to grow as they went through the residency program. It's hard to put into words on how to teach a resident, and maybe you can't put that into specific words, but I think I try to do it by example. I try to do it by judging each resident's strengths and weaknesses and giving them challenges, trying to make them think, not become a robot, not just come to the operating room and do something and go, but to make them think about, even from the beginning, how they're going to position the patient, how they're going to make an incision, how they're going to approach a problem, review the X-ray with them, let them discuss the approaches, and then try and guide them in their thinking as to how I think it ought to be done. And then to emphasize to them to really understand what the patient's needs and expectations are in a particular problem, and to keep that in mind. Not, as we've talked about before, not every tumor has to come out. Not every tumor needs to be totally removed, but one has to keep in mind the judgment that goes into having the best outcome possible. I think we've been fortunate at the Mass General about having very high quality and high caliber residents, and that certainly makes my job easier. But that the development of surgical techniques to in some difficult problems, and to have the patients respond well to that, and then secondly to see the development of the resident and to see them become an excellent surgeon. All aspects have really been very rewarding, and have certainly been worth the time that it takes to do that.
Well, Bob, you've done quite a bit in your life, and we haven't talked about the other major career that you have had, which is raising a wonderful family. You have 4 boys, and can you tell us what they're doing? Because I think that's pretty remarkable that in spite of all this, you really had time to be a wonderful father and husband.
Well, as you alluded to earlier, I'm very fortunate having a wonderful wife, and raising the 4 boys fell to a great extent to her doing. But the oldest, David, graduated from MIT and has worked in research in electronics and computer science. He has a master's degree in that from MIT. He then took actually 2 years away from that and got a degree in religious education, and was for 5 months in Pakistan using both his electronics and his religious background. He's now active working in a research project at GTE, and doing a lot with his church group. The second son graduated from University of Pennsylvania, and he's also in computer science, and he also works for GTE. In fact, all of them graduated in computer science and engineering. Third one graduated from University of Vermont and works for a small computer company in developmental work. And the fourth one, who just graduated a year ago from Northeastern, works for digital equipment in New Hampshire. 2 of them are married, and they all seem happy, and I think that's the important thing. And some people say, well, didn't you want them to go into medicine? And I encouraged them to get an education, try to expose them to everything, and they did what they were most interested in, and they're happy, and I think that's the important thing.
Well, you've been very humble, Bob, but it's incredible what you have accomplished and how you've been able to be excellent at so much. And that's, I wanted to finish by asking you if you if you agree with my presumption when I wrote a little biographical note about you in surgical neurology. I ended up by saying that of all the things you have accomplished, it was my perception that perhaps the one thing that you would want best to be remembered is because your patients did so well. And I wonder if you feel that that in fact was a correct presumption, or if there are other things that you would like to be remembered later on in your retirement, 30 years from now, when you're finally retired.
Well, I think isn't that what we're all working for, is to really to give our patients the best care we can. I think we have to think about education, about research, about advancing knowledge, acquiring new knowledge, but all with that goal in mind of giving a better life for our patients. And I agree with your statement, and I appreciate that. Thank you. I think that I've been asked from what are my thoughts about the future of neurosurgery. What are things going to be like in this decade, the decade of the brain, in the 21st century? Clearly, we're in an era of subspecialization where individuals are, just because of their own interests and also because it gives the patient better care, are focusing their attention in more and more into one area. And I think this will continue. And there will be a lot of difficult decisions to make about how best to set training requirements and certification. But I think the broad areas of neurosurgery are well covered in our residency programs, spine and vascular and tumor and trauma and perhaps pediatrics. And I don't, if one wants to have special training in those areas, why certainly one can obtain that, and that's good, but it really isn't mandatory. But some of the special areas that aren't normally covered in a residency, will certainly epilepsy, for instance, or endovascular therapy, will need to have specialized training. The whole question of the natural history of some of the problems we're dealing with, the question of radiation therapies that deals with some of the tumors will have to be answered in coming years. And in the vascular area, the whole field of endovascular therapy is just in its infancy, and remains to be seen what place that's going to hold. In spine, the new techniques, just a lot of interest now in advancing that field with new investigations. It's hard to know what's going to come along in that. But I think if we keep our standards high, and if we have some guidelines for training, and if we continue the good work that's been done in really improving our residency programs, and in interesting the young person to come into neurosurgery, well, I think that'll be crucial. Why our specialty has a good future ahead.
Good. Would you do it again?
I would do it again. Yes, I wouldn't.
You would go to neurosurgery again?
It's a great profession, and I have never had one regret about being in neurosurgery.
I wouldn't have thought you had, but thank you very much.
Well, thank
It's really
you.
been an honor.
Well,
Thank you.